Welcome to Help for a Hurting World. My name is Ben Collins, and I am the Five Cities campus pastor and also the spiritual care team lead at Grace Central Coast. And thank you for joining us for our third installment of Help for a Hurting World as physicians reflect on COVID-19. And so this evening, we're going to be discussing together this virus in particular and how it's affecting our community. And so I have with me three different physicians from our local community here on the Central Coast tonight. And let me just tell you who they are. So first one is David Leese. He is a population health physician here locally. Then also Cindy Holt is a pediatric hospitalist. And then Jana Reed is an ER physician. And so thank you to each of you for joining us this evening and sharing your wisdom and your heart and your knowledge about COVID-19. So thanks for being here, everybody.
Sure.
Yeah, so they all also happen to be members of Grace Central Coast, and it's a pleasure for us to be able to provide the community with some resources like this through these people here who are really on the front lines of COVID-19 and its impact here on the Central Coast. And so I just wanted to say, we're going to start with some general comments. We're going to hear from each of our different panelists. And in the past, I've kind of been a panelist slash moderator, but tonight I am not qualified to be a panelist, so I'm really just going to be a moderator, and I'll say a few things at the end here. But really, what we're going to do, let me just tell you how this time is going to go. We have an hour together. We're going to hear from each of the panelists, and just from their unique perspective about COVID-19 and the different areas of health that they serve. And then from there, we're going to open it up to questions, and you can put your questions in the live chat there on YouTube. And we have a moderator, someone who is monitoring that, and they will send those questions over to me, and we'll answer them after everyone's been able to have their say here from our panel. And we'll walk through those for a while, and then we'll have some closing comments as well. And so let me just get started here. David, it's been a couple weeks since you sat down with our lead pastor, Pastor Tim, when everything was really starting to get a little wild here, and we had to cancel all of our group worship services, and then the shelter in place took effect here in SLO, and then a few days later statewide for California. From your perspective, David, have you seen anything change significantly on your views of COVID-19, and how are you seeing COVID-19 as a disease affect our local community from where you sit as a physician working to take care and manage a large group of patients in our community?
Thanks, Ben. Yeah, I think as we reflect over the last couple of weeks, there certainly has been just a lot of changes in all of our lives in regards to COVID-19. And COVID-19 as a disease certainly hasn't changed in any way in the last couple of weeks. It's still a respiratory viral illness that's spread through droplets and through sneezing, coughing, talking, aspects that way. And so the basic nature of the disease certainly has not changed in any way that way. We know it also causes a very serious respiratory illness. It primarily affects the lungs and causes a pneumonia in patients who get sick from it significantly. It's about 10 times as potent or strong as influenza, the normal flu that we see seasonally. And what I mean by that is about 10 times as many people get sick from the disease, requiring hospitalization, ICU care, ventilation, than we see with influenza. And just to give another example of that, at the peak of influenza season across the nation, there may be up to 250 or 300 patients that will die in a day through a long influenza season. But COVID-19 already is above 500 per day in the United States right now of patients that are passing away. So again, when you look at the total numbers over a longer period of time, it hasn't caught up, but that's only because we've only been seeing it affect our population for the last few weeks, whereas influenza is over a period of about 20. We characterize the flu season over about 5 or 6 months. Yeah. So the other aspects of things that I talked about a little bit last time with Pastor Tim was its effect on different populations and different age groups, and how that it really seems to have a significant impact on our elderly patients and the vulnerable people in our society. And that is true and has not changed. But a study came out last week looking at the initial response and the initial experience that we've had in the United States. And actually, over half of the patients that were admitted or have been admitted, the first 5,000 patients admitted to the hospital, have been actually in the 40 to 60 age group and not the older age group.
Huh.
And the reason is because really the virus affects different age groups in different ways. In people in their 20s and 30s, it gets spread very easily, but they get, on the most part, very mild disease. People in their 40s and 50s, again, they're still in the workforce, they're still active socially. And so again, the virus affects that age group fairly highly. And what we're seeing is that although it's a lower percentage, when it affects a large group of patients, even a lower percentage will result in a significant number of patients being hospitalized. And then in the elderly, again, although it affects them more severely, because they aren't as social, they aren't in the community as much, just in general terms, the attack rate to that generation is not as high. But when it does happen, it causes more serious disease in a much higher percentage. So I think that is something that we're sort of seeing. And when you see things, reports that it's affecting younger people, it's not that we didn't know that before. It's just that when you have a virus start to spread so widely in the population, even a small percentage of people in a given age group where it might affect severely, you get high numbers because it's a small percentage of a very, very high number. The other thing that we're seeing is that, again, the severity of this illness when people get sick and need hospitalization is a long recovery. People are in the hospital for 10, 14 days. They're on the ventilators for 7 to 10 days, something along those lines. When patients get sick, it is a fairly severe illness. But the good news is we're finding people are surviving from this illness, and particularly people in that middle age group, and especially when there's not other diseases or problems with those patients, that although young and healthy people will get sick and sometimes very severely sick, those patients generally do well and come off the ventilator, but it is a long hospital course and a long journey for them. I think the newer things that have come up since I talked to Tim and we first started looking at this is that we didn't really know how social distancing was going to work, in our society. In China, it's a different society. They clamped down the whole society and basically shut things down, and they had ability to be able to really turn the disease around. In South Korea, they had ability to test, many people in a high percentage of their population, and they were able to manage it that way. But in the West, Europe first, and now in the United States, we didn't have those tools really, and we had to rely on this mass social distancing, which is what we're doing at this point in time. It's what the stay at home or the shelter in home is all about, the social distancing that we're doing. And in some of the places where now things have progressed through for a few weeks, we are seeing things start to improve. And even in countries like Italy that have been hit so hard in the last few days, we're starting to see that curve kind of start to come down a little bit. And so that's positive news that what we're doing and the sacrifices we're making at this point in time from a society standpoint will have effects and will help to turn the tide and have an effect in regards to that. I think the other thing that we're seeing is that we're recognizing that that the way the virus and COVID-19 affects the society is dependent on a lot of different things. So even in the United States, where we have different states, we have different regions, it's going to affect those areas in a very different way, depending on some societal factors, demographics. Area like New York City, you've got dense population, a very urbanized area, mass transit, a lot of international travel where people come from other areas. And that's how the disease got a hold so strongly there. A lot of influx of individual patients that then set seeds in place, or sparks we call them, where eventually those will all grow and turn it into a raging fire in some of these areas. Other areas where there's not people coming in as much, it's less so of a problem that way. And so I think what we're going to see in the United States is there's going to be a wide variation as far as how different regions, different states are able to do things, and how it has an effect from that sort of a perspective. And where we are locally, so at this point in time, taking those things into consideration, We basically now, as of today, have 71 confirmed cases in our county. We have 9 patients that are in the hospital, 1 in the ICU. The cases have been going on the curve that we sort of would expect for the last 10, 14 days. The projections look like in the next 1 to 2 weeks, it's going to be kind of a critical time to see what kind of a surge and a peak we kind of get in regards to our cases and that aspect of things. And so that's kind of what we're looking at. That's kind of where we are right now. The reported cases in our community is a little bit of a hard number to take a look at because our testing has been very limited still at this point in time. We've done testing at our public health department, but that's been very restricted to primarily hospitalized patients and patients that are severely ill. The outpatient arena, which is really where I work in, we've been able to do more testing, but we've restricted that even because of resource allocation to mainly people who have, moderate to high risk in the sense of their age and their underlying risk factors. But that is ramping up. We were having problems with turnaround time of 3, 4, 5, even 6 days of getting tests back. That has improved too in the last week, where we're getting some tests back now in a day or two. We have a couple of urgent cares that are seeing patients in the outpatients, and some of our private physicians are now starting to do testing more in their offices as well. So it is a complex and a changing thing on a day-to-day basis, but I think looking at it from the big picture, what we're seeing is certainly, a very challenging time for our nation and a very challenging time for certain areas of our nation. I think locally, we're in the time frame. We're going to kind of see which direction things go and how things climb in the next week or two in regards to particularly how many cases get hospitalized, because that's a little bit more reflective of the disease burden in the community than the amount of patients who are testing positive, because again, we've been limited in our testing availability. And then finally, I wanted to reflect just a little bit on, again, locally, how things have gone. I think we've had great leadership in our local community as far as the public health department goes, our county. When you think back as to what happened, a couple of weeks ago with, again, these proclamations of the shelter at home, what the state ended up doing, I would consider us to be have intervened on the social distancing, on the mass social distancing, on an earlier side compared to other areas that we look across the country. When we look at Europe and how they've responded, and so I have very guarded, but I have some optimism that hopefully that'll have some significant effect. Our community as well, I think, is a community that's a little bit more rural than a true urban area. We've got a fairly highly educated community that I think has been very supportive of the social distancing measures. And so we've seen, from my perspective, I've seen the community rally around that. I've seen our church just make a drastic change in the way it's, doing its ministry, which is just so encouraging to see that kind of change, and to see Tim up front this morning, 6 feet apart from other people around there. I mean, that's the message that we want to be sending. And so that's my message really at this point in time to the community, is that, I think we've made right decisions. We're on a good path. We still have to wait and see how things come together. And we've still got, some time to see how things are going to evolve and how we're going to have disease present in our community. But for our community specifically, I think we've done as much as we could in a timely way as we could have to put measures in place. And we are seeing speed is of the essence here. I mean, it's a matter of days in those early phases when you start doing this stuff that makes a huge difference as to how the disease is able to take hold in the community, which then you don't see the results of that for 2 or 3 weeks down the road when disease is able to progress. So that's kind of my overall snapshot of kind of where it stands at this point in time, and also as a community where we're at in regards to things.
That's great. That's great. Yeah, and thank you, David, for all that commentary and insight. And I just want to compliment you all on being far more than 6 feet apart from one another here this evening. So nice job. Good modeling in this. And isn't it awesome that technology allows us to have a panel that is quite a bit more than 6 feet apart from one another. So that's great. So Jana, for you working in the emergency room setting on a daily basis, how are you seeing COVID-19 in SLO County now? And how is it affecting that part of the health care system that you work in, kind of right there on the front lines in the emergency room?
Yeah, it's been really interesting. We're definitely seeing cases. As was mentioned, we've had a paucity of testing. It's been very challenging because the testing that we've done has been at minimum 24-hour turnaround and at maximum up to 10 days for send out tests. So we've had to kind of assume that anyone that's come in with respiratory symptoms has this, and we've been able to take the time to separate our emergency rooms for the waiting rooms and the beds in the back. We've been able to make respiratory sides and non-respiratory sides to try to limit potential contamination between them. So what we've done when patients have come in with respiratory symptoms is we can test for the flu. And that's something that has definitely, we had a pretty big flu season this year. And if someone has the flu, we can reassure them, hey, this is the flu. It doesn't mean they don't have the coronavirus, but at least it can give people that comfort that they know that we can tell them what they have. It's been hard for us not to be able to tell people, but we've basically said, look, if you have cold symptoms, if you have shortness of breath and cough and fever, diarrhea, any of these classic symptoms, and we do a test on you or you've had a test as an outpatient, you need to treat yourself as if you have this. So that's pretty much what we're recommending to people. The testing we've been able to do in the emergency department has really been limited to patients who get admitted or are at very increased risk, or healthcare workers or first responders. So that's how we've had to do that. And so we'll have patients, some of them bounce back. Some, we try to send everybody home, and some come back. And when they come back, some have been able to go home again and they've had a positive test. Sometimes they come back and they get a lot sicker and they get admitted, but that's okay. And that's what we want to do. We want to try to limit as much, as much contamination of other people. And so we're definitely seeing this. I have the luxury of tracking all the positive and negatives in my hospitals, and I get to call patients and say, hey, you're testing back positive or negative. And it's been great for me to be able to reassure people as often as I can. And on the other end, sometimes I have to give that bad news. But I've been very, very impressed at how well everyone is taking this. There's a lot of fear and anxiety out there, but patients have been grateful and generous and patient. I've had to change my practice. All of us have, just in terms of the PPE that we wear. So I'm seeing, even non-respiratory patients, I've made it a change in my practice to wear a mask and gloves for every patient that I see, just for protection. And you lose that personal aspect a little bit, not touching people as much and, without that kind of physical reassurance. But, for patients to all be wearing masks, but everyone understands the importance of it. And that's been okay, but that's definitely a change. We have PPE. We don't have as much as we'd like. We have enough to be safe right now. But, that's certainly of concern.
Sure.
I think the level of stress is palpable. Every shift we go to work, my colleagues, my co-physicians, the nurses we work with, everybody down to the lab personnel who draw blood and people who do x-rays and ultrasounds and CAT scans, everybody's been very stoic and we've all been there to support each other. We've had several staff members get sick, and we've had to put them on, quarantine, and luckily most of them have been able to say, hey, you get to come back. So yeah, it's definitely affected our day-to-day operations. Our overall volume in the emergency rooms is down, probably something like 50%. So what that means is that a lot of people, like with the bread and butter type cases that we see, a lot of people are choosing to stay home, which is good. It's good as long as people understand that emergency rooms are there for a reason. So we've had calls, oh, I have this problem. I fell down and hurt my ankle. Can I still come in? I'm having abdominal pain. Are you still seeing us? And yes, people need to know the emergency room is there for them. It's just, if you think it's something that can wait to see an urgent care or your regular doctor, all the better, but we are absolutely there for people.
Yeah.
So I think we're all very anticipatory that this could be the calm before the storm. So I think, every shift I go to, I have to take a deep breath and, think, well, hopefully this isn't, when something bad really happens. But by and large, our shifts have been very, we've had a lot less patients overall. So that's been good. It's given us time to take precautions and make sure that we put our PPE on and we're adequately protected. I think if it becomes a big rush, it's going to be much harder. We've had to change the way we do certain things. We're trying to do less CAT scans, less radiology studies, just to limit contamination.
Mm.
We're changing the way we treat, for example, respiratory patients. We're not giving nebulizer treatments because we're trying to limit anything that could aerosolize a virus. So if patients come in and they have asthma or COPD and they need a breathing treatment, we're giving extended inhalers, not nebulizers. So there will be some changes to the way you're treated. And so we're still trying to figure this out. We're trying to figure out surgeries. You know, we canceled most elective surgeries just to give more beds and room in the hospital and more resources. So that's definitely affected people in the population, the community, because a lot of things have been canceled and have been put on hold. And so in this way, you know, it shows that everybody's pitching in to do what needs to be done. And I've been really impressed.
That's great. It's great to hear, you know, David, you kind of talk about the team effort from a community level, and then, you know, Jana, to hear you talk about the team effort, like within the emergency room and your teams there, and just kind of from people just living down the street and people working next to you in the emergency room, all taking this seriously. That's great to hear that kind of united sense of, if we work together, we can really make a difference here. So yeah. That's great to hear.
And I did want to add one thing about testing too. We are definitely getting more testing capability, and within the next few weeks, we're hopeful that we'll be able to get a much more rapid turnaround test locally. And I think that's really going to help, because then we'll be able to narrow down, you know, people that have this and their immediate contacts. And that's something that's been difficult up to now. It's been difficult to tell people, we're going to send you home without a test and treat yourself as if you have this. You know, nobody likes to hear that, but hopefully, you know, with testing, it'll get better. And with outpatient testing, you know, the electronic medical records that we use, sometimes we're able to get these outpatient test results. And so as that improves, you know, communication between clinics and different hospitals will improve. So.
Yeah, that's great. That's encouraging to hear that hopefully better testing is on the way. That's awesome. That's awesome. Sweet. So we've heard from David, Jana. Now, Cindy, you work as a pediatric hospitalist, where pediatric patients are treated when they have conditions that are at a state where they're needed to be seen and cared for in a hospital setting. So for you, Cindy, how has COVID-19 affected what you do there in the hospital? And from your view in the hospital setting, since you're a pediatric specialist, can you also speak to the risks of COVID-19 for children?
Sure. Yeah. So within the hospital, I think I could echo a lot of what David and Jana have already covered in terms of the preparation and the unity within the staff and the hospital system as overall. The hospital's been working on this for weeks to try to coordinate and organize the flow of patients. And so pediatric patients, if they come in with symptoms, are treated similar to adults in the sense that they're, you know, put in an area away from the other assumed non-infected patients and tested and then treated appropriately. The merciful thing, I think, within the pediatric practice is that COVID-19 does not affect children in the same way that it does adults. And even taking into consideration, you know, the large number of people and kind of the statistics that David was talking about, it still doesn't tend to give them a severe illness. There are obviously exceptions, and then if a kiddo has underlying what we call comorbidities or other diseases that would put him at risk, certainly they could be, but just in the general, just, you know, mainstream pediatric practice, we don't see it. And what's been interesting, as we've collaborated with a lot of the nationwide children's hospitals, and specifically on a lot of conference calls with Seattle Children's, just trying to absorb their experience. And then on a call this week, we had people weighing in from New York as well. The pediatric hospitals are making room for the adult patients, and younger adults are being cared for by pediatric intensivists in the ICU as we try to help our adult colleagues through this process. So that's kind of the pediatric overall perspective. The same thing applies, you know, with testing, et cetera. If you have milder disease, you don't need to be hospitalized. You're not necessarily being tested. if you come into the hospital and you have a lot of the symptoms, you are, and largely the kiddos are having other viruses that we can assure them are part of the disease process. I think most of the positive pediatric cases in the county thus far are at home, and so that's good. Hospital at large, again, I think Jana covered it well. Same thing, we're just trying to work together on this thing, and it is a grim mood when you go into the hospital. We're all just kind of stoic, and it's just a heaviness and a sense, but it's a calm. It's everybody's trying to just get in line and do their job and do it right, and every day we're figuring out something new. It changes frequently, like, oh, if this happens, we're going to put this patient here, or hey, what about this? And like Jana was talking about, not nebulizing albuterol and delivering oxygen in different ways. So it's always a moving target. And I can say people that have had to come in have been really understanding of the process. We've had to admit patients, and really the hospitals are on lockdown now, where you're not having a lot of visitors. Only one parent can come in. There can't be any trading off. And normally people can get, they're stressed, they're in there with their kid, and they can get pretty unhappy pretty quickly. I haven't seen that. Everybody is just really cooperative, understanding, patient, and grateful for what we do. And that's just been real encouraging, that sense of we're all in this together.
Yeah, that's great. Well, thank you for, just your care for those kids, and just the way that you're leading those teams over there as well, and rallying everyone together to be ready for whatever's next. And David, one of the things that you mentioned earlier, which I thought we had a little kind of pre-conversation that I thought was really helpful, was I think you gave 3 different kind of social distancing, home isolation, and could you just define those for us? Because you said that there's been some confusion, and just when you even brought up those terms, I was like, I would love to just have those clearly in my mind, and I'm even having a hard time recalling exactly what you said. So can you give us those 3 kind of different orders for people to follow, and who they apply to and why?
Sure. So when we talk about, ways of trying to stop the spread or limit the spread of the virus, there's different degrees of trying to separate ourselves from other people to avoid that. And so at the highest level, there's these ideas of social distancing, which have to do with trying to avoid any sort of contact with the virus, either directly from another person or from contact of typically a metal or a plastic item that may have been touched by someone with the virus. And so again, it's a droplet transmitted disease, which means small droplets when you sneeze, cough, or talk, not for the most part aerosolized in the air. So an example is if you get in an elevator, you're not gonna, if someone was in the elevator 30 seconds before you got in there and they had COVID-19 or the SARS virus, and then coughed a couple times with air, you got in 30 seconds later, you're not going to get the virus from the air. Okay, it hasn't stayed in the air, it's not sticking in the air. But if they coughed on the button, that push the floor that you're going to, and they had touched that with a hand that they just sneezed into, and then touched the floor they were going to, you come in the elevator a minute later, touch that. That's the way it can be transmitted, not through the air that you breathe, but more that way. So the social distancing is 6 feet apart, and maintaining that, because that's about as far as a droplet will go when you sneeze or cough. And so that's the reason for that distance. And then it's obviously things like, wiping things down, avoiding touching, in public, items that are going to be touched upon, that kind of thing. So that's the social distancing, and we're doing it at a mass level at this point in time from a society standpoint, primarily when we're in public areas. And that's kind of what the order was that we had to, hunker down at home and follow those practices. So the other item is what we call quarantining. So again, quarantining is a situation where a person is exposed potentially to the virus, and we send them home, basically, not to go in the public space, to wait and see if they develop disease. So in the situation with this is, if you, like Jana, if she was in the hospital and for some reason forgot to wear her mask, and a patient came in and she saw that patient, And she didn't have a mask on, the patient didn't have the mask on, and we find out later, a couple of days later, that patient had COVID-19. She had a high risk exposure. Well, she would be told to go home and quarantine, which basically means stay away from everybody, avoid household contact, even approach, and wait 14 days, which is what we kind of feel is the clearance time before someone can get cleared, who's been exposed. And so that's another level of basically separating a person who's at risk but doesn't necessarily have the disease while we're waiting to see if that disease develops in that person. Even if Jana went home and we did a test on her that first day after she saw that patient, there's no reason to do that test because it takes the virus at probably at earliest 3 or 4 days to incubate and become, have disease in a person and start then, shedding the virus. So even tests in those situations aren't helpful until at least some time down the road. And nowadays with test limited, we're pretty much telling people to wait and see if symptoms develop. And then home isolation is what we call when patients either have presumed COVID-19, because now we aren't able to prove it in everybody because of the limited testing, or a test positive COVID-19. And those patients we tell to go home and to home isolate. And the recommendations for that are stricter than social distancing. Those are recommendations that involve staying in a single room, separating yourself from other household contacts, trying to wear a mask, just a regular mask or a homemade mask between yourself and caregivers, so that you avoid droplet transmission that way. Obviously the normal things are washing hands and things along those lines. But the purpose of home isolation is trying to avoid spread to household contacts. The China experience is about 80% of the spread was in household contacts, not people getting it from going out in general public. And so it's much harder to avoid contact and spread in the household setting. But again, in somebody who we know has disease or has suspected disease based on symptoms and a high prevalence of disease in the community, that would be the approach we would take. So there's different sort of tiering of, I guess, of how we separate people. And it sort of depends on whether you've been diagnosed and you're a patient, in which case we isolate you in the home, whether or not you are sort of at risk for developing disease, high risk for developing disease because of a high risk exposure, or whether you're just practicing things that we all should be doing, okay? And that's how that kind of plays out.
That's great. That's great. Yeah. Anything you guys want to add, Cindy and Jana, to that at all?
No.
Pretty much covers it. That's
Yeah.
great. Great. And so
I think one thing, the impact, like for the impact on healthcare, we've all had to analyze, how we can minimize the spread, well, to ourselves. That's how we're protecting ourselves at work, but also our own family members. So that's been a huge strain on, myself and my colleagues, especially in the back of our mind. We're wondering, well, what do we have to do to not bring this stuff home? And we all do that to a degree, but I think it's been much more important now. And some people are actually not even sleeping at home, or they sent their families away, or, how do you get from your car without contaminating anything and fit your clothes in this plastic bag? And, so it's definitely taken a life of its own. At least in our household, I've had to change the flow of things. And that's been a big strain, but we're doing everything that we can so that we're protecting ourselves, but also our family members. And that's just something that, until it happens to you, you don't think about.
Yeah.
Very true.
Got it.
Same for me.
Yeah. Just a heightened sense of safety there for your own home. Yeah, that makes
right.
sense. Yeah. So a question came in: how are local COVID-19 cases being treated besides the order to isolate? Antivirals, vitamins? How are they being treated locally?
Well, at least from an emergency department, from an emergency medicine standpoint, we're telling people to treat themselves as if they have the common cold. There's some studies that show that certain medicines should be avoided. Like some people say, don't take anti-inflammatories. I haven't read those studies personally, but you need to treat your fever. Tylenol is safe, and ibuprofen probably is safe, but some people aren't using it. Steroids don't necessarily help unless you have underlying asthma or COPD. And staying hydrated and resting is really the most important way to treat this. When people have to get admitted, it's because they're hypoxic. It means they're not getting enough oxygen. And so really oxygen is the only treatment for this. So, yeah.
Yeah, there's been debate around different medications. There is a group of medications, chloroquine and hydroxychloroquine, which is a medicine called Plaquenil in the United States. In South Korea, they use these medications a fair amount. And so there's been a debate as to whether or not these are medications to consider treating. And so the most common combination therapy that's been proposed is a combination of Plaquenil or hydroxychloroquine and azithromycin, which is an antibiotic that we use for different, usually upper respiratory infections. Fairly controversial as to whether or not there's evidence to show it's beneficial. There are side effects, especially in people that have conduction problems in their heart or have some underlying heart arrhythmia issues. The studies that have been done, there was some studies in France that were not well done as far as the clinical aspect of it. So most of the recommendations that I've seen for the variety of hospital systems and from infectious disease experts that are treating these patients from an infectious disease standpoint is we would not use those in an outpatient setting at all. So someone would not be sent home on those prescriptions. And I think I have not seen anybody suggesting that in any of the areas that I oversee or involved in from that standpoint. When patients are sick enough to be in the hospital, someone sick enough to be ventilated or on a ventilator, there are some protocols that include using those medications, but that would vary from hospital to hospital, from infectious disease specialist to infectious disease specialist. The other thing that they are starting to just identify is actually getting serum from patients who've had the virus and developed an antibody response. You can isolate, we've isolated now some of the antibodies that looks like are protective that the body produces when you get the infection and then develop protection against it. And so there are trials being done or that's starting to be developed as far as, again, something that would be used in a very, very severe patient, very sick patient who's not responding because this would not be widely available necessarily. There's a variety of antivirals that have been used, particularly for HIV over the years, that have also been tried in COVID-19. Most of those have now gone through enough of randomized trials or good clinical trials to show that for the most part, they're not effective. So a medication called Kaletra, a couple other ones that are in those antiviral families. There is one, remdesivir. It is one that's being looked at. Again, very limited supply, however. And so again, in some of the large institutions, academic institutions across the country, that's being potentially offered. But even that, I think they're no longer enrolling patients in. So it really is limited to, like Jana said, to supportive respiratory care, oxygen, supporting the airways, using sometimes the inhalers, like Jana mentioned, not necessarily the nebulizers, but the inhalers. And again, steroids have been shown, if anything, to not be beneficial and actually harmful. So we don't treat people typically with steroids.
Yeah. Cindy, anything you want to add from your perspective in your world over in pediatrics?
No, I mean, everything that is really in the treatment realm is for now widely studied in the adult realm. And I mean, David and Jana covered it. This is a virus, and like any virus, we don't have usually a magic bullet for it. It's no different in pediatrics, but again, with the pediatric illness being fairly not as severe, kids do get better with that supportive care, and then individualizing it, based on the case by case, what's going on otherwise. So
along these same lines, another question just came in: is intravenous vitamin C being used locally?
Not that I know of.
Yeah, I'm not aware of that either. I know there's been some talk about it, but I think that would be outside the realm of sort of standard medical treatment as far as what we would recognize as being something that's been studied or been looked at and proven to be beneficial.
So not currently is what you understand.
Yeah, I mean, there may be some providers that are using it that are more along the lines of naturopathic approaches or things that way, but certainly it isn't something that's been had any scientific study behind it or proven effectiveness that we're aware of.
Got it. Got it. Another just kind of general question. If you could just, as simply as you could, just define the vulnerable, because David, even you indicated, seems like that's been a little bit of a moving target, at least with when it comes to ages. With the people affected and having serious disease symptoms. But can you just define the vulnerable? Because for instance, like if you have had, like, what does it mean to be immunocompromised? If you've had radiation treatments for cancer in the past, does that mean that you're in that category? How does that, if you were born prematurely and have underdeveloped lungs, like what are some of those things that might just be outside the anything heart and lung, which is kind of what I've heard personally. But if you can, if maybe, and maybe that's the best answer, but how would you guys define the vulnerable as you have learned about the way that COVID-19 is affecting people worldwide?
Well, I think the strongest things are age is one thing for sure. So over the age of 65, but the caveat to that, as we've mentioned, is that as the disease becomes widespread in a population, you're still going to get people who are across the spectrum age-wise who are going to get sick. Not necessarily pediatrics, but potentially 20-year-olds, 30-year-olds, not frequently, but to some degree. So age is a relative risk factor, and again, in the old, above 65, 70, we certainly see higher mortality rates and higher severe disease. The risk factors that we've identified are coronary artery disease, so people who've had a history of heart disease in the sense of heart bypasses, those types of things. Hypertension seems to be a major risk factor. I don't understand quite why, but it is separate and distinct from coronary disease, which is a little bit unusual. It's not oftentimes a risk factor that we think of in regards to chronic infectious disease. Diabetes is a risk factor. And particularly people who have what we call metabolic syndrome, which is a combination of diabetes, hypertension, problems with their lipids and their triglycerides. That patient population, particularly in the middle age, and particularly men are affected more significantly than women, both in the frequency of illness as well as the severity of illness. So men in their middle ages who have diabetes, hypertension, problems with their lipids, that's sort of a group that we really see besides the elderly that are at higher risk of having more severe disease. And then less common things are things like chronic kidney disease, so patients who are on dialysis. And immunocompromised patients are generally patients that are on some sort of treatment and that affects their immune system. So the most common things would be chemotherapy, not necessarily radiation therapy, but chemotherapy. And then patients who are on immunosuppressants for a variety of other problems, particularly like autoimmune diseases, like rheumatoid arthritis, lupus. There's a variety of medications that fight autoimmune diseases where our own immune system is attacking our body, and the treatment for that is to sort of suppress that immune system. And so anybody who's on a treatment that way, whether it be a chemotherapy type agent or a biological type agent that suppresses that immune system, they're going to be at higher risk. So I think those are the broad categories in that regard. I may be missing one or two, but that put people in that higher risk category as far as beyond age that way.
Great. Anything to add, Cindy, Jana?
Substance abuse, like alcoholism, kind of adds to that too. So.
Cindy, could you talk about pregnancy? I've had several situations or questions asked in the community and from friends about pregnancy and the risk either to the mother and or potentially to the fetus as regards to viral exposure in this sort of setting?
Sure. So pregnant women are also not being affected as much, although the state of pregnancy could make one a bit more at risk for disease and severe disease. What has not been seen in mainly in the China studies is vertical transmission. That means that if the mom has the illness, the baby does not get it from, virus in the mother's blood or the process of being born. So the general rule, the recommendation is that if a mom has a baby and she's positive for COVID, that they've not shown transmission in the breast milk either, but the recommendation is that the baby be separated from the mother and cared for by another family member, or if there's hospital personnel available, housed in another area of the hospital. And then when the baby is with mother, she's allowed to breastfeed, but should wear a mask and try to protect the baby. And then once home, until she's recovered, someone else would do all the diapering and the other general care for the baby, and then she would breastfeed and wear a mask. So that in general, the risk to the baby from the pregnancy, delivery, and then breastfeeding has not been shown to be transmissible. Again, virus not found in breast milk and not transmitted directly from the mother to the baby. So. Mm-hmm. And I think just in the pediatric population, Ben, you'd asked about who would be at risk. I think, again, because we just don't see that bad of a disease yet, as it becomes more prevalent, I think we're going to always learn more every day. But, I would classify a pediatric patient similar to what David talked about. If that patient has cancer and is on chemotherapy and has low immunity in general, or potentially someone with asthma, potentially a premature infant who is maybe a toddler and has asthma from some of the underlying lung disease. But again, with the premature care being as good as it is now, I don't see that like I used to in terms of the lung disease in premature infants, because the NICU care has gotten so much better with that. So I think that one's going to be something that evolves over time as more patients become exposed and sick.
Great. Well, another question has come in, and this is not about treatment of disease, but kind of preventative. And the question is, are there supplements you would recommend we take to add a measure of protection? I've heard we should take vitamin D and C and zinc as 3 examples. Thank you. So preventative supplements, any studies that you guys have read or any recommendations from you guys on those?
I haven't read anything personally.
No, and I would say just maintaining your general health, sleep, nutrition, hydration, exercise is probably a lot more beneficial than any single supplement. But that's my opinion, and I have not read anything either.
So I've continued to exercise regularly, riding my bike, which is what I do for both, fitness and also for sanity. And so I think, I would totally agree that, nutrition, doing your healthy habits, things that you do, spending time in the Word, prayer, the things that Tim mentioned this morning in regards to, how we can stay, spiritually not down in regards to this, our emotional health and how that's going with maintaining, communication with our friends, those that are supportive to us, our family, those are the types of things. I mean, as I look at this again and look at our community, there's going to be some disease that comes, but, I think the burden of this for a community like ours, which is not a large urban area, which, probably will be able to manage the acute illness, in a way that is okay, it's going to be the collateral issues, the emotional strain it takes on people, the financial challenges that people are, facing in regards to just the disruption in our economy and the things we've had to do. And so really, guarding ourselves that way, I think is very, very important. And in working with it. And I think all those things affect our bodies, affect our immunity, affect, how we're able to deal with something like this if we were to be exposed or to get the virus itself. And so, so I would echo the other panelists as well.
That's great. So as we kind of come to, I got about 10 minutes left. I think just, it'd be great to hear from you guys just kind of on your, we've been talking, our Sunday morning series is called Hope for a Hurting World. This is help for a hurting world. And yet as Christians, we have hope. And so, for you guys, as we've seen an escalation of some of the bad news regarding COVID-19, particularly in the last few days, what do you find as a place to find hope in all of that as a physician, from both a personal and a professional standpoint? So David, you want to get us started there?
Sure, Ben. Yeah, I mean, this has been a roller coaster. Got to tell you, in the last couple of weeks, not just the disruption of our lives in a lot of ways, which we all are feeling too, but certainly from a professional standpoint. I had 5 conference calls last week with doctors in variety settings, some outpatient, some that were hospitalists in the hospital, doctors in small practices in the community struggling to survive because, they've just had such a disruption in their patient flow. And, it's just a very, very challenging time for all of us. And we're not even in the thick of it, in the sense of an area where the disease has penetrated super strong. And so, we have some dark days ahead. I mean, there's no question about that. We are in the midst of it right now across the country. I think we're a little bit further along the curve in the sense of how things are going to play out in California. So we'll see how that pans out in the next week or two. And again, but I am hopeful for our community. I mean, the way the communities come together, the hospital systems, which typically are competitors, are working together on this in a very healthy way. Great partnerships with, again, the county and the public health. Many of these people I've worked with and known for many years, the leaders. They're very competent, professional. We've prepared well for a surge in the case a surge happens in our community, such that we won't see situations again, Lord willing, of having to ration ventilators or to do some of the types of things that I think that are happening right now tonight, in New York and some of these areas that are affected. And so, that brings me hope for our community. It's not the same hope necessarily across the country in different areas, because I think there are areas that are going to be suffering much, much more. But to see our community respond the way they have, to see us, both from a leadership in the healthcare and public health arena, and then to see us come together as a community to follow along with that, brings me hope. And like I say, I mean, we've got some time ahead of us. We've got some collateral issues that are going to be very significant, but there's hope in that regard. And then, ultimately what's going to take care of this is a vaccine. A vaccine is the end game on this thing. And I actually have some hope in that regard. SARS was the original coronavirus that kind of went nasty on us. And that was 15 years ago or so, where it was an outbreak. It was the coronavirus involved with that. And it is in the exact same family as this virus. It's this virus just mutated and evolved a little bit differently. But that virus was very aggressive. It killed 20-30% of the patients that it attacked, and it got very limited. There was only 800 patients that died from the original SARS outbreak. But as a result of that, there was a lot of research into vaccine development against that disease, because we weren't sure how that was going to play out. And that research kind of died off because we were able to manage that disease in a public health manner, isolating patients, identifying patients, and just the nature of the illness was different than this in a lot of different ways. But restarting that research, getting down the path of vaccine development, we have many more tools from a biotech standpoint now to be able to accelerate that process. It's not going to be something that happens in 2 or 3 months. At the most optimistic, we're looking maybe 6 months, but realistically, probably looking more like a year. But that is something that ultimately will be the thing, and we'll need to develop that. We'll need to manufacture it. We'll need to distribute it, because it needs to be a full population for that to, immunizing a full population to be able to make that happen. But that brings me some optimism in the sense, and some hope in the sense that, we do have an end game. There'll be steps between now and then. We're not going to be locked down until then. There'll be steps we'll be able to take as a society, and that are sound public health steps. But again, that end game in regards to getting that vaccine and protecting us is something that I think brings some hope in regards to looking at the situation. And then again, just on a personal level, I found hope these last week or two just in reflecting on God's presence. spending time in his word, spending time in prayer, and just remembering his presence through his spirit. And on a daily basis, that brings hope in a way that helps get through the day.
Yeah. Long days for all of you. Sure. Yeah. Definitely a need for his presence. Yeah. Thanks, David, for sharing and just connecting that to just your walk with God. That's awesome. That's awesome. Jana, how about you? What's it like, for you to have hope professionally and personally, given kind of the dark days that may be ahead with COVID-19?
Yeah. Well, professionally, I think we're very lucky to live in the area that we do. And we haven't been hit hard like some of these other areas. And there's a lot of lessons learned. We're getting reports, and people are so willing to share what they've learned, what's worked, what hasn't worked. And so all of this is giving us more time to prepare. And so that is really hopeful, because that gives us time to work on our flow and change our practices, and find out how things are going to work in our own emergency departments and hospitals. So that's great. And I think also, in addition to a vaccine, more testing is going to be helpful, and even testing so that we can figure out with antibody testing who has been exposed and recovered from this. And for, at least for us in the medical field, we'll know who's then immune. So who can then better take care of some of these questionable patients in the future. So that's all going to streamline our operations and also decrease a lot of anxiety in the future. Personally, I think my faith has really helped. Those of you who know me, I'm multi-generational in Grace Church, born and raised. My parents go there. My kids go there. So a lot of you that know me know that we've had our own family issues as well. My husband's battling cancer, and we've had a nephew who's died of cancer. So I've had to put my faith in front of me, and I still do on a daily basis. It doesn't make this any easier, but it gives me the perspective that, I need to be thankful for every day, and I ask for God's guidance every day. I pray before every shift, and I have hope that he's there with us.
Well, you can say it doesn't make it any easier, but it does make a difference.
Yeah.
I think that's so much of what we say is like, it's truly that hard, and yet the hope is still there. And
Yeah.
It's great to hear you express that. So thanks, Jana.
Yeah.
Cindy, how about you? Dark days of COVID-19, how do you find hope?
Well, so much of what I would say is just, would be in some way echoing what both of the other panelists have said. I really liked what a statement David said earlier that sort of sums it up. I find a lot of hope in what has really come forth in this as the brotherhood of medicine. It's just really been encouraging to see. It's a linking of arms of the medical community, from the administrative people at the hospital and all their organizational efforts, and those of us on the ground. And there's been times it's really challenging to look at my ER colleagues, and there's fear in their eyes, and we're scared because of what they know is happening in New York, but yet we're all ready to face it together. I don't personally in my practice have a lot of I don't have the challenges facing me, at least with the pediatric patients per se, that the adults do, but my heart hurts for them, and I want to be there to help them, even if I'm an intern in the on the adult ward, working as such, just so that I can help with the adult medicine. And I think that feeling is across the country as I've participated in national calls, and like Jana was saying, the eagerness to share information, and the fact that we're on the West Coast and kind of receiving it and getting a chance to prepare. There's just, it's a brotherhood that I haven't seen before and experienced, and it's encouraging. And it gives me hope that through that, there will be great advances, hopefully quickly, in things such as vaccines, maybe new antivirals to beat the illness. And then just spiritually, it's that very present, God's very present help in this time of trouble that is my encouragement every day. I feel like he's present, and I know that intellectually, and even when it's hard, that's just a source of hope. And just knowing that Jesus is the great physician, and somehow being able to humbly participate in that. I cry easy, I'm so sorry. I knew I was gonna do this at this part, so That's just me. I don't even like to pray out loud in growth group because I'll always cry. It just happens. But anyway, that just the privilege that we could partake with the Lord in some sort of role in that is humbling, gives me hope, and gets me through the day. And I don't cry as long as I don't have to talk about it. But it touches my heart.
Yeah. I love what you said, Cindy. Just like partnering with the Lord in his being the great physician. And, that's what Christians believe. Like when Jesus was on the earth a couple thousand years ago, walking around doing his ministry, he was healing people of all of their disease. It said, as many who came to him with sickness, he healed them all. Didn't matter what they had. They all walked away with perfect health. And so Christians believe that Jesus is not just showing that he has a big bag full of tricks and that he has power over disease with no purpose, but instead he's showing that he has power over disease because the kingdom that he is going to rule over forever has no trace of disease whatsoever. When Jesus sent out his 72 followers to go and proclaim him and his good news, he told them to go out and he gave them power to heal. It says in Luke 10, to go out and heal the sick, Jesus said to them. And when they go to a city, heal the sick in it and say to those in that city, the kingdom of God has come near to you. So in Jesus's healing of people and in those who he sent out to heal, all that he was saying, all that he was communicating is, this is what my eternal kingdom is going to be like. Jesus' eternal kingdom is not up in the clouds. We're not going to be spirits forever. When Jesus was raised from the dead, he ate fish. He was a real person. He showed that he wasn't a ghost because he actually ate things, and he was able to be touched and felt. And that's because eternity is here in a recreated world where there's no sickness, no sadness, no tears, no death. It's all been done away with. And that is the living hope that we have in Jesus, the one who died and yet has come alive again from the dead. And he is the first fruits from the grave. And that's our hope, that even if COVID-19 takes us, takes me, takes my life, I know that death is not going to define my life, that COVID-19, that disease, won't define my life forever. I'm going to have eternal days because of what Jesus has done of perfect health. And that is a distant but true hope that helps us in the present. And that is what I love hearing you guys talk about, just wanting to link arms with God in the present. And I'm just saying, like, and let's also, know that we can look forward to a time where all of you guys will be out of a job, and me too. No one's going to need to be taught about God, and no one's going to need to be healed of illness. So we'll have to find a new career, I guess, something like that. So, but that'll be good. So I just want to thank you all again for being a part of this panel and just sharing your wisdom, sharing your heart. And, I said it just kind of came out of my mouth earlier in our talk, but you guys are some of the heroes of our community. You guys are totally caring for us, and you are putting yourselves at risk all throughout the week and every day, and to guard the health of the valuable people of the Central Coast. And so thank you. Thank you from me. Thank you from, I'm sure, from all those watching. And I just wanted to say, like, keep at it. And you truly are heroes. So thank you. And for all of you who are watching, this is the end of our third episode of Help for a Hurting World. We're going to have another episode this upcoming Tuesday night, and it's likely going to be on COVID and anger and how the response that we can have. There's been a unity, but also in small parts, there's been a sense of strife and competitiveness and even outbursts of anger in our community and around the world. And so we're going to talk about anger from job loss, from shortness of supplies, etc. And so you can join us on Tuesday night at 8 p.m. right here on our YouTube channel to watch that episode as well. And thank you again for tuning in. And I want to let you know too that the two previous episodes were on anxiety and loneliness, and you can find those also on our YouTube channel. Thanks for tuning in, and we hope to see you again. Have a great rest of your evening.
Thanks.
Thank you.
Ben.